This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the Journal of Stroke and Cerebrovascular Diseases, published in 2026. It's titled Endoscopic Evacuation versus Stereotactic Aspiration for the Treatment of Supratentorial Intracerebral Hematoma, a comparative study.
This is a timely topic. For our residents and colleagues listening, we know that the management of spontaneous intracerebral hemorrhage, or ICH, has shifted significantly toward minimally invasive surgical techniques, or MIS. The big question has always been, which MIS technique is superior and why? This study specifically looks at endoscopic surgery, ES, versus stereotactic aspiration, SA.
Exactly, Dr. Aris. While many studies focus solely on hematoma volume, this paper dives into the secondary injury, specifically perioperative perihematomal edema, or PHE. They evaluated 82 patients with supratentorial ICH, 35 underwent endoscopic evacuation, and 47 underwent stereotactic aspiration.
Right. And the goal wasn't just to see who cleared the blood better, but to evaluate the relationship between those perioperative PHE volumes and long-term functional dependence. Let's start with the surgical efficiency. What did the evacuation rates look like?
The results were quite striking. The endoscopic surgery group achieved a significantly higher hematoma evacuation rate compared to the stereotactic aspiration group. We're looking at 89.1% for ES versus only 66.8% for SA. This was reflected in the postoperative acidual hematoma volumes on postoperative day 1, which were 5.6 milliliters in the ES group and 16.6 milliliters in the SA group.
That's a significant difference. As a surgeon, I'm not surprised that the direct visualization of the endoscope allows for a more thorough evacuation than a stereotactic catheter. But the real meat of this paper is how that clearance affected the brain tissue surrounding the clot, the edema.
Right. The researchers measured PHE volumes using CT scans at multiple time points, POD 1, 3, and 7. What they found was that while both groups started with similar baseline PHE, the trajectory changed quickly. In the endoscopic group, the PHE volume increased until POD 3 and then stabilized. However, in the stereotactic aspiration group, the PHE continued to increase significantly through POD 7.
So the SA group had a lingering inflammatory response, whereas the ES group saw a plateau. By POD 3 and POD 7, the endoscopic group had significantly lower PHE volumes. Why does that matter for our listeners in the ICU and the clinic?
Well, it directly correlates with functional outcomes. The study followed these patients for 6 months using the Modified Rankin Scale, or MRS. They defined functional dependence as an MRS score of 3 to 6. They found that the SA group had significantly higher MRS scores at the 6-month mark compared to the ES group.
And they performed a logistic regression to see what was actually driving that poor outcome, right?
They did. They found that the PHE volume on postoperative day 7 was an independent predictor of 6-month functional dependence. Specifically, the odds ratio was 1.053. This suggests that the persistent edema seen in the stereotactic group, likely due to the larger amount of residual blood, contributes to worse long-term recovery.
That makes perfect sense from a neurosurgical perspective. With stereotactic aspiration, you're often leaving behind a larger clot burden. That residual blood breaks down, releasing neurotoxic products like thrombin and hemoglobin, which drive that perihematomal edema. With the endoscope, you're clearing nearly 90% of that out on day 0, essentially turning off the source of the edema much earlier.
Precisely. The paper emphasizes that the higher evacuation rate in ES is likely the key factor in reducing that secondary injury. By stabilizing the PHE volume by day 3, you're protecting the penumbra around the hematoma.
It's a compelling argument for endoscopy, especially for those of us deciding between these two MIS techniques. The study suggests that if we want to minimize long-term functional dependence, we need to be aggressive about minimizing POD 7 edema, and endoscopy seems to be the more effective tool for that.
Definitely. It's a great reminder for residents that minimally invasive doesn't just mean a small hole, it means a smaller footprint of secondary injury.
Well said, Dr. Alara. That's all the time we have for today. Thank you for joining us on the Neurosurgery Hub podcast.
See you next time.